Our next presenter will be bringing you up to speed on collaborative efforts here in North America, working with families to advance how the disease of FTD is understood and how to inform how it will be treated. Dr. Nupur Goshal is a neurologist at Washington University in St. Louis, Missouri. She also serves as an associate professor of neurology and psychiatry at the Washington University School of Medicine. A graduate of Northwestern University's Feinberg School of Medicine in Chicago, she's board certified in neurology by the American Board of Psychiatry and Neurology. Dr. Goshal's research focuses on the mechanisms underlying neurodegenerative disorders, from the tau protein in Alzheimer's disease to the progranulin protein in FTD. Dr. Goshal, we're thrilled to have you join us here today and look forward to hearing your presentation.
Thanks, first of all, for the invitation to participate in this leg of the marathon. I'll be talking a little bit about my own journey into this field, as well as the title suggests, launching lefties and advancing ALLFTD. I'll explain what those are, and coming together to further FTD research. As Susan said, at the Washington University School of Medicine, you'll hear about the NIGHT Alzheimer's Disease Research Center in just a moment. Next slide. Not to bore everybody first thing on a Saturday morning, but I mentioned my disclosures of interest, mostly to see that research comes from, is sourced from all sorts of manner, from the National Institutes of Health, but you'll also notice prominently featured in column 1, AFTD. So we've worked quite closely over the years in developing research and things in this space. Next slide. So a bit of my journey into frontotemporal degeneration research. We're going to have a couple of next for me, thank you. So I started off at Washington University initially as a neurology resident, and then stayed on for a fellowship at the NIGHT Alzheimer's Disease Research Center. Part of my activities there were engaging with FTD families that had long-standing relationships with our institution, primarily under the auspices of Drs. John Morris and Allison Goach. It was a part of my fellowship activities to meet families, one of the largest families with progranulin in the country, a tau family as well. And I was conducting visits both on site at the Washington University campus, but often in-home visits in respective geographic areas in the country that were closer to home for families, a little bit easier to meet extended families. And we were kind of an on-the-road team. And this is how I got to know families in their own environments as well, and just kind of branches of the family often. What came to be is, while this was an interesting aspect of my fellowship training, we started talking about how we could best move this area forward. Certainly, we'd had contact with these families over decades, really, before even I came on board, but how we could bring them together more systematically, studying them under some more consistent leadership. Next. And so what came to bear was some local resources. So we at Washington University are the headquarters for the Dominantly Inherited Alzheimer Network, or known as DIAN. And there was a lot of, so it's an inherited forms of Alzheimer's disease that group, and I'm part of that as well, study. So it's kind of some infrastructure about how one could go about evaluating individuals from familial forms of FTD. And there was some funding, as always, needed. And so there was a Birch mechanism available through the institution. That's basically a K award. And one of the interesting aspects of that mechanism is that we needed external reviewers. We asked our folks you'll hear frequently today, Drs. Bruce Miller and Brad Beauvais, who were kind enough to have served as external reviewers and have really been advisors and mentors ever since. Next. Next. Thank you. So it was really the existing DIAN infrastructure and the funding together that really allowed me to establish a cohort then of these inherited FTD families. Circa 2013-14. I'm going to give you that date for just a moment and for a reason. But essentially, we did what we tried to do in bullet point number 3, sub A type of thing above, which is we needed a mechanism to bring these folks together systematically and under some consistent leadership. Yeah, ooh, we're flying through. Okay, so in 2013-14, as I was developing cohort, and the fact that Drs. Miller and Beauvais knew of my interests, just seemed to dovetail with what was already brewing in the field. A bigger notion, a broader notion, that we need to bring our resources together to best study these kind of underserved families and this underserved area of research. And we need to bring our forces together. And that was the inception then of both Artful and Lefties, as you see here. Next slide. So my foray into the larger group was primarily through LEFTDS, the longitudinal evaluation of familial frontotemporal dementia subjects. Here we were looking at what we call the big three, so folks who came from families where they had a known mutation in the family, whether it was in the MAPT or tau gene, GRN for progranulin, or C9 or from 72, we more commonly call it just C9. But these were folks from one, in their family was known to have a mutation in one of these three genes. However, the individuals themselves did not need to know if they had carried the mutation or not. It just needed to be from the family. Next. This is the nuts and bolts of what LEFTDS set out to achieve, what we call the specific aims. I will synopsize this for you, so you don't have to be bored with the smaller font here. But basically, the idea was, again, this broader notion of how do we bring these families together under an umbrella of research. And in point one, we were interested in looking at individuals who were already expressing symptoms, were already doing battle with the disease, as it were, and how we could use kind of the tools we already had at hand to better understand them, both from clinical evaluations, some paper and pencil testing, behavioral assessments, and so forth, and MRI, last but not least. The next bullet point, we then wanted to move that needle back. So once people have symptoms, that's already one set of challenges, an important population for us to be able to address for sure. But what we've often learned in taking a hint from the field of Alzheimer, that we probably need to be looking at earlier and earlier. So what is that asymptomatic phase? So folks who we know are at risk because they're mutation carriers, yet not yet having any symptoms. And what do those people look like? Again, with those same tools and measurements. So what can we better assess and better even pick up on who those people are? Then in aim 3, we wanted to do something new and novel. You'll notice the word traditional is underlined in the first 2 bullet points. And now we wanted to also bring something new to the space. Are there new and better ways we can measure, make measurements? The thing was, a lot of the tools that have been available to us in the field have been born out of the Alzheimer field. Fantastic work, but not always a great fit for our people. So we wanted to make sure we had a novel aspect where we were looking for new and better ways to best characterize our people. The final point being the genetics was, of course, kind of the fundamentals of why folks would be in LEFTDS, and biofluid has to do with blood and spinal fluid measures. And we were really interested in looking at all these people from the asymptomatic to symptomatic phase and seeing how they did what we call longitudinally or over a period of time. Next slide. So these were the original sites. In the seafoam green highlighted, UCSF, Mayo Rochester, and Penn were the lead sites, the parental sites, if you will. And the other 5 sites, Washi right there in the middle, is being one of the 5 performance sites. So these are the original 8 folks who started off LEFTDS. Next slide. And this is a lot going on here, but I'll just explain that again up across the top. This was the overview. The lead sites with UCSF, Mayo Rochester, and Penn, and then in the lower left is WashU. What we're basically saying here is how we divvied up the work. So we decided that the number we would like to recruit at a minimum was 300 folks from families from those big 3, as I mentioned. And then we were all going to contribute equally into the same pot for every researcher in our consortium and beyond to be able to benefit from what we were doing, whether it was clinical information, MRI, DNA, blood work, and spinal fluid. Next. And this is how it laid out. The math got rejiggered based on the funding and so forth. So often, even though we thought we'd only have 3 visits over 5 years, most often we were able to get at least 4 visits in. And that was because year 1 in these studies is usually just building the infrastructure, and did take a little bit of time to start those things up. But as time went on, we were able to get additional funding and support up to even 4 evaluations during that first 5-year period of time. I mentioned that we were trying to bring in 300 people. It was as divided below. So 100 who had mutations from one of the big 3, who were already expressing symptoms, 100 individuals who didn't yet have symptoms but had the mutation, and then another 100 who are usually siblings, neither having the mutation nor having symptoms. As I mentioned before, the evaluation kind of distilled down to asking about some of the things you heard about in the FTD registry, kind of what your functional lifestyle types of measurements. Also, we say neuropsychological, always seems a loaded term. Basically, some paper and pencil testing that allows us to test how one's brain is actually functioning. MRI, blood, and CSF, spinal fluid, as I've mentioned before. Next. So I spent a few minutes here on what LEFTDS was. And like I said, that was my foray into the field. But ARTFL was a sibling mechanism that was funded in the same time frame. So we'll talk about ARTFL for just a moment. Go ahead. A lot here as well, but I'll leave it at this to say that ARTFL, we're very much a companion entity to LEFTDS, but was even a little bit more, let's say, eye on the prize on what we need to do to bring this research to the participants. So let's create a clinical trials network. Individuals then in this group would be what we call clinical trials ready. We're interested in what would it take, what do we need to know, and how do we need to measure things that would be meaningful in the period of time during the duration of a clinical trial, a year, year and a half, that type of thing. In this space, we were able to also bring in some of the new molecular imaging that was becoming available at the time. You'll notice in LEFTDS at that time, amyloid PET imaging was available. The tau was very nascent, but was able to be folded into ARTFL. And there was also a training aspect because we certainly need both researchers and clinicians who are well trained in this space to help both our patient populations and our research participants moving forward. Next slide. So all said and done, basically, a lot of us realized, and we wore the hats under both ARTFL and LEFTDS, that it made most sense to have a combined multi-center FTD studies. We kind of harmonized the activities under both and really functioned as a single unit. They both focus on FTD, and there was reasons that made sense to do the overlap. So kind of in synopsis here, LEFTDS again was participants who came from families with a known mutation in tau progranulin or C9. You can think of LEFTDS as having been a more in-depth, what we said, longitudinal study than ARTFL, really trying to understand the diseases and developing a better, just really the understanding of what that looks like over time. Then ARTFL was probably a bit broader, and again, with the eye on the prize of being very clinical trials oriented. As I mentioned in that one grid, that the LEFTDS individuals were asked to come back for 3 and maybe even 4 visits over a 5-year period of time. The ARTFL participants we were looking at a baseline and 1-year visits, again, really trying to understand what it was that we could measure during that time that would be informative moving forward into clinical trials. Next slide. So this is what the ARTFL combo LEFTDS sites looked like. So we had their original H sites that were the LEFTDS sites. They also became ARTFL sites, Washi included. And then we started adding more sites that were, at least at the inception, ARTFL only sites. We started getting a little bit better geographic representation in the country. Next slide. And all said and done, at the end of those 5 years is what our enrollment looked like. A little bit of content here. So up top with the sporadic FTD individuals, this is the kind of the folks who came through the ARTFL pipeline. LEFTDS in the bottommost dark purple oval. So we clearly hit our goal of 300 and then some. And then we learned through LEFTDS, I'll talk about the Washi Experience in just a moment, there are more families who come from and have strong family history and genetics outside of the big 3. So we identified those individuals as well in that kind of next middle circle. Next slide. You already heard, just dovetailing in with the last speaker about the FTD registry, but this we kind of think as was a main outcome of the research in those first 5 years. That's great. We're finding these individuals. We're finding new families even. We really need to have a central registry repository where we can help a space for them to come together and then be able to help populate studies moving forward, including clinical trials. Next slide. So that's a little bit of the traipse through the past. So looking ahead, the next leg of the marathon, if you will, next 5 years, we've all come together. Like I said, ARTFL LEFTDS is really effectively functioning together anyway. So we've just formalized that both in logo and theme and heart and mind, calling ourselves ALLFTD, ARTFL LEFTDS, longitudinal, frontotemporal, lobar degeneration. There's a website there to see more about this. Next slide. These are now the member sites for ALLFTD, mostly the original sites that have come on board over time from LEFTDS, ARTFL, some looking to spread the geographic representation as well. Next slide. So I was asked to also speak about our Washi experience more directly. So I started off with what my own journey had been. So remember, we were really interested in having a mechanism where we could see these individuals systematically, as opposed to kind of piecemeal as had been done before I came on board, and under more consistent leadership. And that, to some extent, became me, OSU. So we had a place for our families that we'd known, the largest progranulin family, the tau family we've known for decades. But of course, as we started these endeavors, we met and discovered new families along the way, another 2 mapped tau families, and some C9 individuals where we're just developing their pedigrees now. Next. So one of the things that Washi is perhaps, I think, well known for, if you think being known for spinal taps is a thing, we as a site greatly value the spinal fluid collection and look to provide an optimal lumbar puncture experience. Now, our colleague here, Ann Fagan, talks about there's nothing that sounds good about a thing called a spinal tap or a thing called a lumbar puncture. So she would like for us to redub lumbar puncture as a lovely procedure. So we pride ourselves in doing lovely procedures. Next. And nearly 100% of our participants for our lefties at our site have had their spinal fluid collected for this study. So we know what we're doing. We make sure our participants are game and comfortable doing so. I say nearly, one individual was on a blood thinner, and so it really wasn't like medically sound to do a spinal tap on him. Next slide. So continuing with our experiences, we continue to marvel at the lefties families and their commitment to us. Next. So we've actually been able to harness our interactions with our lefties families. They've served as focus groups and have provided valuable feedback for related studies. One in particular that ALLFTD has been extremely supportive of is our TANGLE study, where we're particularly looking at the tau protein and how it's processed in the tau-related diseases of that due to tau mutation FTD, PSP, and CBS. We basically sat down with our family members and thought through what their hurdles and barriers to research were and figured out ways to facilitate their enrollment and ensure retention. These folks are amazing. For Tangles, they need to come in to do 5 lovely procedures over a period of a few months. And they're often younger folks. They're gainfully employed. We figured out ways that we can make it work for them and us. And they've come back and completed the whole set of the spinal taps, no problems. Next. So, of course, we've learned a lot from these interactions, and we're hoping to be able to apply those lessons learned now in the COVID era. Next. Speaking of, next, COVID era challenges. So as you all well know, research was largely put on hold across sites, but we were all at our own speed, but slowly and steadily ramping up, WashU included. Next. So I'd say one big area of significant strides has been telehealth. So while that wasn't with research in mind initially, we're seeing it as a way of opening up new opportunities for participation. I can tell you here at Washington University, we'd been interested in telehealth, but probably only 2 or 3% of our total clinic visits were being done that way prior to COVID. But we've all rapidly had to become very comfortable with new online platforms, we being both researchers and our participants. We have folks in the VCP space in particular who are looking at testing out telehealth versus the gold standard in-person neuro exam, seeing how well that holds up. That would provide a tremendous amount of kind of increased bandwidth, if you will. We have a pediatric epilepsy group at Washington University that's learning that they thought telehealth was going to be their way of bringing in the most severe participants. But in fact, they're able to pick up even milder and milder symptoms than previously observed. If we think we want to move the needle back, this may be a really interesting way to do so. Next. So ALLFTD is actively moving into both remote and hybrid, meaning both combinations of remote and in-person visits to ensure that the FTD research does not stagnate, far from it, but rather moves forward robustly. Next. And so with that, I'll take questions. I guess I won't be on video, but happy to take questions, Susan.
Nupur, thank you so much. So exciting to see the Artful and Lefties progress, all the information that they uncovered, and then the success in getting them. There you are.
There you go. Oh, I guess I was one more click away than I thought. Well, anywho, at least I come back for the.
There you go. We knew you were there. As I was saying, just great to have the 2 studies merge and continue for the next 5 years. It's just really exciting. So we do have some questions for you. Can people join ALLFTD as new participants under COVID conditions?
Yeah, certainly more challenging than not, but absolutely. When we say we're ramping back up, we're looking to do it full force. So yes, we'll be able to bring in new participants.
Great. And the next question, what's the best way for somebody without a strong family history to contribute to FTD research?
So without history, was that it? Family history? Absolutely.
Right.
So within ALLFTD, I didn't break that down further, but much like we have before, we have an arm where we can have individuals with FTD, certainly with what we call sporadic, no family history FTD, be recruited as well.
Excellent.
And of course, the registry. The registry is at least a first foray.
Right. And as you say, if people do join the registry, as Lakeisha and Diana said in the last half hour, they'll stay informed of clinical trials and other research opportunities. And a lot of those are open to people without a family history or without a known gene, for sure.
Absolutely.
The next question is, are the results of this research available for non-technical readers to the study? So I think they're, lay people want to stay informed of what ALLFTD might uncover, and what's the best way for them to understand what the research results are.
That's a fair question. So our first interest, of course, was to get the word out there among our peers. And so, yeah, it hasn't been non-technical so much just yet. But I imagine, Susan, we'll be chatting more about having webinars that are a little bit more accessible to our participants as the data are now, fully analyzed and available, at least within the scientific community. But I know there are sites that have support groups, locally based webinars, and I imagine, like I said, that we'll probably be working with AFTD to have a few webinars as well.
Absolutely. To follow up on that, so for someone who does not have a genetic mutation, is there any research going on as to the cause of their disease, such as environment or toxins or something else?
So perhaps not so much through our consortium. I never say never, right? There's always interest. I have one of my participants who's particularly interested in water quality and air quality, and what's being learned about hyperphosphorylation and changes to the tau protein due to those factors. But there's a little bit more of that in the Parkinson's space. I imagine it's just a matter of time before we bring it into FTD as well.
And just to follow up on the Nupur, is it true that we really don't, people who do not have a genetic mutation, which is probably more than half of people with this diagnosis, we really don't have insight at this point as to why they develop this disease?
That is absolutely true. I mean, to be honest, we are, in common company here, we are well trained and well versed and know what we're looking for. But we certainly see several people, who come to our clinics where they've been in flux with their diagnosis, and we're even just recognizing the FTD entity itself from a clinical standpoint, let alone kind of really getting down to mechanisms of why. This really is still a fairly young field, especially on the clinical front.
Right. Yeah. Another question, is it true that patients with FTD do not have amyloid plaques? So
yes and no. So yes, in terms of when we think of what FTD is and the spectrum of pathology that's present, we don't think of them as being amyloid-based diseases. That being said, we do know that amyloid accumulation increases with age. Whether it has consequences in the FTD population or not, I think is also why we're interested in this molecular imaging that's available to us. But certainly FTD is not defined, any of its varieties, by one's amyloid content.
And I guess you're reminding me something that you and other investigators in the field have taught me, which is one of the reasons there is so much interest in studying FTD is because on the whole, our patients are younger. And so within a younger brain, there are fewer just age-related changes to make the view more complex and hopefully help people like you hone in more on the actual what is the disease process.
Absolutely. And we certainly see that, even when we do clinical evaluations, certainly people come in with their most active and current concerns. We spend a fair amount of time talking about the early days and early years before there are maybe other health issues or other factors that might muddy the works. Really interested in what years 1, 2, and 3 look like, and the same will be true for brain changes as a result.
Yeah. Okay. This person says it's said that people with behavioral variant FTD don't have insight, and this person wants to know if there are any exceptions to that.
Each person is their own set of challenges for sure. So we do often talk about the lack of insight in DV-FTD. We also talk about the lack of insight in our Alzheimer's population. I mean, most folks who come to us in clinic don't think they're either having any degree of difficulty or not to the degree of difficulty the family is indicating. So the insight issue is rampant in the neurodegenerative disorders, maybe a little bit more pronounced in DV-FTD, but I wouldn't say that every single person. It may be an appreciation to the extent of which their insight is an issue.
One final question, Nupur, if you don't mind.
No, absolutely.
Can you just share with us what the most important aspect is to these natural history longitudinal studies in studying especially a rare disease?
Yeah, so can you still hear me? I think we've been cutting out a little bit here towards the end.
Okay, sorry.
So the longitudinalness, right? So the value and the benefit of the richness of the data are staying on track and coming on through. The benefits are reaped on a much longer timetable. So I know for the individual participant and family, that can be a little hard to we keep coming and what are we getting out of it? But what we're gaining is a much broader perspective of what the diseases look like, how much do they overlap or don't they? So please, sticking with the game plan as best we can. Certainly with COVID, we've had a lot of pauses, but really it's the longitudinal, the value of the data that we are able to collect and the depth of understanding comes from being able to stick with us at each site for your annual visits.
Great.